Hi everyone, I am Mingyu Lu. Today I'm going to present a sensitivity analysis on deep reinforcement learning for sepsis treatment. Reinforcement learning is a machine learning method where an agent would perform an action to interact with an environment, such as a target. By doing so, it will receive reward and enter into a next state. By iterating this loop, the agent will learn a policy to maximize the reward. Recently, there has been a lot of interesting research of reinforcement learning application in healthcare. But these RL application in healthcare face challenges that the other real-world RL application face. First, it is hard to translate high-dimensional continuous state and action into RL settings. Besides, designing a reward function is difficult. Even giving a good reward, we might still be trapped in a local optimum due to the limitation of those RL algorithms. But regardless of the issue that I just mentioned, there has been a lot of research showed that the result of those RL allocation can be unstable and hard to reproduce. Early this year, the US FDA proposed a regulatory framework for AI and machine learning application in healthcare. It especially points out that the robustness and stable result should be considered a standard guideline for the application in healthcare settings. And that's the motivation for this work. We consider the robustness of those RL application as the first step toward future success. So we perform sensitivity analysis for sepsis treatment. Sepsis is the body's extreme response to an infection, which would cause multi-organ failure. It is a life-threatening medical emergency that commonly seen in intensive unit care. For sepsis management, maintaining blood pressure is a major goal. Physicians will usually prescribe intravenous fluid and vasopressor to achieve this goal. So we could frame this sepsis management into a reinforcement learning problem. So we try to train a dueling double deep Q network to learn how to manage sepsis. We define 1 hourly laboratory values in the EHR as our state. Then we compress patient history with LSTM to summarize the patient history. Reward is defined as the log odds of probability of mortality for 2 consecutive observations. For the action, as I just mentioned, intravenous fluid and vasopressor are crucial treatments for sepsis management. So we simplify and discretize these 2 types of treatment into 5 bins according to their dosage, so that we would have a 5 times 5 action space. Here is a heat map of physician's action distribution. The y-axis is the dosage of IV fluid. The x-axis is the vasopressor. The color, the density of the square represents the numbers of actions being performed by the physician across patient time. So with the heat map that I just mentioned, we are able to analyze the behavior of those DQN agents. We especially designed 2 evaluation metrics. The first one is action distribution, which is the frequency of each type of action across patient time. The second one is initiating rate. Initiating rate is basically the probability of action taking a non-zero value given that there was no treatment being given at a previous observation. So now we can start our sensitivity analysis. First, we are interested in the effect of different time window. By different time window, I mean the observation frequency within patient trajectory. So theoretically, with infinite data, it is preferable to use shorter time window because shorter time window would improve confounding adjustment and allow agent to learn more flexible and dynamic strategies. But in reality, we only have finite data, so this ability might be detrimental. So in this sensitivity analysis, we're interested in the effect of different time window. We train the DQ agent with 1 hourly data and compare it to the DQ agent trained with 4 hourly data. Our result shows that the DQ agent trained with 4 hourly data is much more aggressive compared to the DQ agent trained with the 1 hourly data. The 4 hourly agent is much more willing to prescribe treatment to patients and is more willing to start a treatment given that there was no treatment being given at a previous observation. So we have to be careful about choosing a time windows to train our RL algorithm. Second, we are interested in analyze the effect of different embedding, which is state representation. For the state in reinforcement learning setting, it should contain sufficient information so that it could adjust confounding. It should also contain an effect modifier, which has the ability of conditional average effect of an action on future rewards. Finally, the state should satisfy Markov assumptions. So for time series data, what people would do is that to keep long-term dependency, they would summarize the previous history with the recurrent neural network, and they would select their model mostly based on the loss or accuracy. But these black box model, given that their accuracy and loss is similar, would have an unexpected effect on the outcome policy. So in this analysis, we experiment two commonly used recurrent embedding model. One is GRU, the other one is our baseline LSTM. As our result shows that the action distribution trained with the GRU is much more distributed and more extreme. DQ and GRU also demonstrate lower initiating rate compared to the DQ trained with LSTM. In some cases, DQ and GRU prescribes 27 times more IV fluid compared to the DQ trained with LSTM. We also classify patients according to their risk. For high-risk patient, the DQ trained with LSTM prescribe more IV fluid, whereas DQ trained with GRU prescribe more vasopressor. That being said, the recommended policy is totally depend on what kinds of recurrent embedding that you choose. Finally, we are interested in the effect of long-term versus short-term reward. Ideally, a reward function should summarize long-term utility of patient state. But the reality is that researchers will usually use short-term reward at each time step because it is easier to estimate the association between short-term reward and action. So here we design a long-term reward which encodes two factors. The first factor is the improvement of patient status within the ICU stay. And the other factor is the survival time of patient after their ICU discharge. And C is the relative weights of these two factors. So we are interested in analyze the effect of long-term versus short-term reward. Our result shows that the DQN trained with a long-term reward is much more aggressive. It is more willing to prescribe IV fluid and vasopressor to patient. And in some cases, the IV fluid are being continuously given across their ICU stay. So we have to be careful about choosing different reward. The conclusion here is that choices matters a lot. These seem similar or even trivial factors might have a huge impact on the outcome policies. We really need a benchmark to evaluate the robustness of those reinforcement applications. And we consider robustness as the stepping stone to the future success of those applications. Thank you for your attention.